Okay, everyone, welcome tonight's webinar. My name's Al Rundio, and again, I will be your host for tonight, and I will introduce our speaker at the end of this presentation. We do this each week to introduce you to the American Society of Addiction Nursing, because we don't know if we have any new people in the audience, and that's why we do this, so bear with me for about 5 minutes. We are doing 8 webinars. This, I believe, is webinar number 5 already, so they will run through the end of August. We want to thank our sponsors, and the big sponsor here is Recovery Management Solutions, who really is the one who is sponsoring our webinar platform, and we really thank Suzanne Kinkle and this company for sponsoring our webinar. You want to keep your cameras on, you are allowed to do that, but you do want to keep your phone muted through or your computer muted through the entire presentation, because whether you realize it or not, if you're not muted and you're doing something, if you're cleaning dishes or something, everybody hears it and it distracts the presentation. We will entertain questions at the end of the presentation. You want to post all questions in the chat box. At the end of the presentation, I will read them. And then in order to get CE in particular, you got to complete the surveys. And the link to each session survey is on the schedule page and also on the website. This conference has been approved for 8 nursing contact hours from the California Board of Nursing. That's 8 for the entire series. Each webinar is an hour to maybe an hour and 10 minutes. So you get 1 contact hour for each night of the webinar. As soon as you complete the survey online, you will automatically receive your certificate in your email. All of the sessions are being recorded. They will be archived on the schedule page for viewing. If you're unable to participate in the live session, you are able to review the recorded session and also receive the continuing education credits. I want to introduce you to the ASAM Board of Directors. Our president is Bill Lorman. Our vice president is Susanna Luna Kinkle. Our treasurer is Bill Lorman, and our secretary is Virginia Coletti. We also have 3 board members, Carolyn Barrett, Fran Campbell, and Mary Armstrong. This is the schedule. Now, I want to just mention one schedule change that you will see next week on the slides, and I believe it has been posted on the website. But for next week, August 10th, I actually will be presenting what I would be presenting in August 8th, week 8, August 24th. Dr. Ferguson has a conflict, so he will be presenting on August 24th, and my presentation on holistic addiction treatment will be next week. And so the presenter for tonight is Adam Barrett. Let me introduce him and give you a little information about him. Adam is a registered nurse with greater than 20 years of clinical experience in critical surgical intensive care in one of Boston's top hospitals. Adam earned his Bachelor of Science degree from Kerry College and a master's degree in education and counseling psychology with a concentration in addiction studies. Adam's clinical experience has been primarily focused on the adult patient with complex medical, surgical, and social service needs. He brings passion for working with these impacted by substance use disorders, including the licensed clinical practitioner whose practice has become impaired by substance use. Through Adam's volunteer efforts in the areas of advocacy, peer support, and 12-step sponsorship, he remains active on boards of multiple organizations and agencies that provide physical care, advocacy, education, rehabilitation, and workplace training for individuals in recovery and transitioning back into the workforce. And you can see the learning objectives. Tonight's presentation is focusing on CNS stimulants, contrasting the difference between amphetamines and methamphetamine, looking at common signs and symptoms of methamphetamine use, and discuss the signs and symptoms of withdrawal from CNS stimulants in general, and methamphetamine specifically. With that, I will stop sharing my screen and let Adam put up his slides. We want to thank our presenters, our attendees, and our sponsors. And we'll see you next week on August 10th. So I'm going to stop sharing, and I'm going to let Adam share his screen and put his slides up.
Hi, everybody. I apologize for the delay. As Al said, my name is Adam Barrett. I live in the Boston area. I'm thrilled to be able to do this. I was so grateful to Donna, Al, and Bill, and everybody involved who requested that I do something, and I was really eager to do something. And central nervous stimulants, and in particular methamphetamine, is a rampant problem right now in many areas of the country, across the country, and outside of the US as well. So focusing on this has been great for me to go back and do some of the research. And unlike opiate disorder right now, where there's some medication available to help treat withdrawal symptoms, there is nothing available for methamphetamine. So treatment options are limited for folks, and addiction is rapid onset. So what I thought I would do is I would talk a little bit about stimulants in general, but then really focus on the methamphetamine problem. Donna, if you could go to the next one. So obviously, thank you to all of you for the opportunity to be here. I have no disclosures to tell you about. I refused all the money Donna offered me, didn't I, Donna? So no conflicts of interest there to share with you. Next slide. So in looking at what you can possibly do in an hour with such a big topic, I know we all suffer from that, right? What I did is what I usually do. I build a presentation, and then I realized that it would take me 4 hours to present it. So how am I going to get it down to 1? And I sort of rehash it to try and get it down to the basics, the foundation, and so that therefore people will have a jumping off point to want to go on from there and learn more. So what I chose was to really focus on looking at the commonly used central nervous stimulant medications, and then discuss how they differ between the stimulants that are used as a clinical treatment versus the ones that are really being used in an abusive way, the illicit, in particular methamphetamine. Then to also focus on the signs and symptoms of methamphetamine abuse or use and abuse. And if anybody is familiar with this topic and those who use methamphetamine, it is very obvious very quickly that something drastically has changed for that person. And I also really wanted to discuss the signs and symptoms of withdrawal. Again, with methamphetamine, because withdrawal is extremely harsh. Rapid onset of withdrawal can last a long period of time. And again, there is no substitutes except supportive therapies during that process. And for those who don't know, methamphetamine abuse, there's a very, very low margin of success with treatment, which I hate to put that out there, but it is the reality. And the studies show that it's difficult to find people with long-term recovery from methamphetamine abuse. And I'm going to talk about that a little bit more as we go. So next slide, Donna, if you would. So CNS stimulants, it's a class of drug that obviously when ingested, what it will do is stimulate the brain, speed up the brain, and it also speeds up both the mental and physical processes that are going on in the body. So this increased energy really improves attention, alertness, and also, of course, will elevate your blood pressure, heart rate, and respiratory rate. And when you start looking at nursing considerations for somebody who has long-term abuse of a stimulant, you can see where the cardiac issues come into play with the chronic tachycardia and such. They also will decrease the need for sleep. They will decrease appetite, which is why you see people with profound weight loss. Improve concentration and confidence, and that's not always a good thing. I mean, it improves some people's confidence to a point that they overextend themselves, thinking I can basically handle anything, that I'm Superman kind of syndrome. And on top of that, it'll lessen inhibitions, because the feeling is that it's so euphoric that it's like you feel like you can do absolutely anything. What does that do? If again you think about nursing considerations, it sets up all sorts of risks for injury, risk for self-harm. So the ingestion of central nervous system stimulants increase the level of one or more of the neurotransmitters. And I think we've all, I'm assuming most people have heard the basics of addiction and what we now know about the brain and the flood of dopamine. So dopamine, norepinephrine, and serotonin are the major players here as well. And what I find interesting is when you talk about opiate use disorder, or whether it be alcohol use disorder, or any of the others, we all know really it's the same brain process that takes place, right? So that's helpful. Knowing the differences between the different items of addiction is really what is challenging for most folks. Just to warn you, I have 3 munchkin cats, and one is about to jump on me, so don't get startled. So they may also have other effects depending on the actual drug itself. So there are some drugs that will directly or indirectly increase other levels. And the same thing occurs, obviously, when you ingest something like methamphetamine. So the CNS stimulants, the prescribed ones, they can be used to treat depression. Here's one. Clinical attention deficit and hyperactivity disorder, and narcolepsy. So those are when the meds are being used for a clinical purpose, right? And we hope that the patient, or what is it Donna says, patient, client, we hope that they're taking them as prescribed, correct? Having done so, it focuses the attention enough that that individual can perform better. Prescription stimulants are typically taken in pill form.
Somebody's speaking, please unmute. Please mute yourself, who's ever talking.
Okay. If I can break tomorrow, I'll go up there. I guess I'll go to
I had to change.
Should I try and keep going?
Yeah, just a minute.
Okay.
Whoever was just speaking, please mute yourself. We can hear you and it's disrupting the webinar. Okay, Adam, I think you can go.
Okay. So prescription stimulants, basically they're all pretty prescribed as taken orally. But they can, in fact, actually be snorted, smoked, injected, in any other form you can think of, or another can think of. And those prescription meds obviously can become medications of abuse as well. So some people will take the prescription stimulants and try to improve their mental performance. For instance, those who are like cramming for exams, somebody who decides they're going to take a stimulant to help them study all night and prepare for and prepare for classes and that sort of thing. Sometimes they'll misuse them in order to attempt to improve their grades. And other adults may use them for memory issues. So for instance, dexedrine is a common medication that is used after neurological illness or injury to help somebody who's having trouble with concentration and memory. And that stimulant will actually help that person focus when taken prescribed. So the stimulants for treating narcolepsy and those things, they have some harmful effects and potentially have effects.
I had to ask for another.
Excuse me, Sabrina, could you mute your phone? Thank you.
So basically, even the prescription ones will have the same physiological effect, lessened, of course, if the patient is taking the medication as prescribed. So prescription stimulants include the common ones, which most of us, if you work in a clinical environment, have heard of Ritalin and Concentra, and some of those, and dexedrine and Adderall that I've already mentioned. So Donna, if you could go to the next slide, that would be helpful. So all the stimulants differ slightly in their availability and their ability to increase certain levels of neurotransmitters. And that will help, that helps determine what effect it'll have on the body. But stimulants are basically classified as Schedule 1 and Schedule 2. And Schedule 1 is the designer amphetamines, and those are the ones that are being cooked up in meth labs, clandestine meth labs. And So they are Schedule 1, which of course means they have no significant or no clinical value that we know of. But the Schedule 2, now you'll notice is amphetamine, there's cocaine, and there's Ritalin. So those are the ones we've discussed that do have therapeutic value when they're taken as prescribed. And they are used to treat a real classic medical condition. So, but obviously the Schedule 2s can be abused as well. And sometimes that is the step into the methamphetamine world for some people. So there are also some differences in the length of time they'll act in the body. And on my other slides, my other slides that I just sent along the course of the program here, I have some little cards that basically show length and duration of time, but we can talk about that in a moment. But what happens with methamphetamine, the difference between the two is really a methyl group was added, a molecule was added to amphetamine to make it methamphetamine. And the addition of that molecule allows methamphetamine to last a whole lot longer in the body than an amphetamine does. And it also penetrates the brain easier. And it's less likely to be detrimental. It has a less likely detrimental effect on the heart at lower levels versus the higher levels. And I'm going to talk in a minute about the amount of that people might use in a given day. So misuse of prescription stimulants. So if somebody is prescribed a stimulant, they are considered misusing it, of course. If they take more than prescribed, or if they're taking someone else's medication, or taking medication only for the effect of it as opposed to what they're attempting to treat. So when misusing prescription stimulants, people can swallow the medicine as in its usual form. They may also crush it, the tablet, or open the capsule, and dissolve it in water and inject it in a vein. And this is a term you'll hear folks use called either pointing. If somebody mentions that they point the drug, that means they inject methamphetamine. Another term that's used often is bumping. So injecting it, and folks are using literally tap water, syringes that may have been used before and washed out manually. So they'll dissolve it in the liquid, inject it in the vein. It also can be smoked in a glass pipe. And the glass pipe is referred to as an oil burner pipe. That what happens is it turns the methamphetamine crystals into a vapor. So the glass heats up, you roll the drug onto the glass, and it turns into a vapor, and that is what is inhaled. The prescription stimulants increase the activity of the brain chemicals, the dopamine or norepinephrine we've already mentioned. So the dopamine is involved in that reinforcement of the reward center in the brain. It also affects, of course, your blood vessels, increases your blood pressure, increases your heart rate, has an effect on blood sugar, and also makes many folks tachypnic, even at rest, at tachypnic. That is, the body's metabolic demand is so high, literally high, from the high that they're also receiving. So Donna, if you could go on to the next one. So there's tons of statistics out there, and I spent a lot of time reading through them, trying to think of what was most appropriate, and I tried to pull a few. And you know how it is with statistics. Some are 5 years old and some are 2 years old. Some information is a little bit harder to gather than others. But the National Treatment Episode Data Sheet reports that in 2014, approximately 53 people per 100,000 were receiving care at specialized addiction treatment facilities involving methamphetamine. So pausing right there, in the treatment world, there really is no treatment program that I'm aware of, and I've done a lot of digging, for folks that are specifically attempting to get recovery from methamphetamine. There is Crystal Meth Anonymous, obviously very similar to the 12-step program of AA and NA, but finding treatment programs for folks who are addicted to methamphetamine is very difficult to do. But as you also may know, typically today you don't see people with only one substance of abuse that they're using at a time. So it would be very rare to meet somebody who's using methamphetamine and not learn in the course of speaking with them that they also use GHB, or they're also using Molly. They're smoking marijuana. So we're talking about obviously polypharmacy here and polyaddiction. But getting a treatment program, helping people to maintain long-term recovery from meth abuse is really, really difficult. The United States government reported in 2008 that approximately 13 million people over the age of 12. It really, it kills me right here when I hear them mention an age of 12 in the same sentence as methamphetamine. It's bad enough to see adults struggle, but 12. But they found that folks as young as 12 had used methamphetamine already, and 529,000 of those are regular users. So those are pretty scary numbers. As of 2015, the National Institute on Drug Abuse, or NIDA, reports around 6% of the American population, again, age 12 and older, had tried methamphetamine at least once. Now, I want to stop at the once for just a moment and tell you there are people who report one use and they do not stop.
I don't know who this guy is.
Rosemary, can you mute yourself?
Hold on, hold on. I can't get in.
So again, for an individual to become at least psychologically dependent, I try and separate psychological dependence from physiological dependence. And how I do that in my mind is, if somebody tries something and they're like, wow, that was great, I can't wait to do it again. And they think about it and they think about it. Well, they're not necessarily physiologically dependent yet. They haven't had the drug in the system long enough, but they're at least psychologically dependent enough that they're psyched about doing it again. And you know where that's going to lead. It's not going to turn into, oh, that wasn't such a good time after all. The drug treatment admissions due to methamphetamine and amphetamine abuse tripled in the US from 3% to 9% from 1996 to 2006. Excuse me. The United Nations Office of Drug and Crime estimated that worldwide production of methamphetamine, I almost slipped when I read this, methamphetamine or amphetamine type stimulants, including meth, at nearly 500 metric tons a year, with 24.7 million abusers. I don't know if everyone online here is from the Boston area, but if you read the newspaper in the past week or two, there was a very large drug raid conducted. 8 people were arrested. Actually, several I knew from the recovery world a few years ago for meth trafficking. And the volume of methamphetamine, GHB, and some of the other designer drugs that were obtained from these 8 individuals was just massive. It was a truckload. Pretty amazing. Some states have a much higher percentages, such as Hawaii, where 48.2% of people seeking help for drug-related or alcohol abuse in 2007 were meth abusers as well. So the numbers are pretty high. Donna, if you'll go to the next slide. There are also culturally specific pockets, I like to call them. For instance, in the gay community, methamphetamine abuse or addiction is astronomical in the gay community right now. Socialization, the way folks interact with each other, a lot of it is now around what they call the party atmosphere. And it's no longer about getting together for a couple of cocktails. It's about getting together and sharing meth pipes. And it's pretty alarming to see a whole population of people become so entangled in one particular drug. I wanted to show just the layout of CNS stimulants in general, because obviously I'm talking about methamphetamine specifically, and that's one of several. But obviously there are other stimulants out there that are used for clinical reasons, as we discussed. So I just wanted to be sure that folks had at least a copy of that. Donna, if you'll go to the next one, that would be great. So methamphetamine is a highly addictive stimulant drug that affects the central nervous system, as we said. It's typically used in the powder form, but again, it can be ingested. So it can be snorted, smoked, bumped, or injected. And another way, the term bumped also means, if you've never heard of the term, a booty bump. Basically, people will dissolve methamphetamine in water, crush it, dissolve it in water, and give it to themselves rectally, because you absorb it so quickly that way that the high is almost instantaneously achieved, similar to smoking. The onset is very rapid. The term methamphetamine has been used, or amphetamine, excuse me, has been used broadly to refer to a group of chemicals which are similar, and they have stimulating properties, and methamphetamine is included in that group. So according to NIDA, methamphetamine differs from amphetamine, and that at comparable doses, so if you look at similar doses of methamphetamine and amphetamine, the methamphetamine is the most powerful. It gets to the brain faster. It is a far more potent stimulant. And that is why they believe an individual will become so dependent so quickly. So a question I know that has come up a lot with folks is, well, if it's made and people can make it in their own clandestine labs, I know we've heard the horrible stories of house fires and children getting hurt and others getting hurt by a meth lab explosion. This is one example photograph of a person's home meth lab. This is actually, compared to some of the ones I've seen, this is actually really neat and clean and tidy. But if you look at the ingredients that go into methamphetamine, and again, thinking back to nursing considerations, if you're taking care of this population of people, think of what they're injecting, smoking, snorting, or booty bumping. Acetone, which is basically fingernail polish. Ammonia, the fertilizer, that's also in some cleaners. So those in combination. Pseudoephedrine, hydrochloric acid, which is made to used to make plastic, is part of the ingredients in methamphetamine. Lithium batteries, the lithium from lithium batteries is in methamphetamine. Brake fluid is another common ingredient. The sodium hydroxide, or lye, is also a component. And then also sulfuric acid. So when you look at this combination, again, go back to nursing considerations, and just these chemicals that are under people's sink sometimes daily, they're flammable, so there's risk for fire there, there's risk for burns, there's risk for ingestion, accidental ingestion. And then you have a situation where they're all being mixed up and cooked in a lab. So I think when I think about that, I need to stop thinking about it, because it makes me a little crazy to think about it. But those are the ingredients that folks are ingesting. If you go to the next slide, Donna. So when an individual is smoking methamphetamine, what they are doing is they're creating a vapor in this glass pipe called the oil burner. We already mentioned the crushing it to powder form for other ways of injecting. Some people take it in a pill form because they can't stand the taste of it. And then there's bumping. If you've ever heard of the term tweaking, or someone being referred to as a tweaker, personally, as I think Donna is someone who is in the same camp, I don't like any of those calling people by any particular name. But when someone says that somebody is tweaking, what they're referring to is a very identifiable physiological behavior that the person might not even be aware of themselves. It's involuntary muscle spasms, it's twitching, is the constantly looking for things. This is either they're incredibly high on high doses of meth, or they are coming down from a high and heading for what they call the crash. So tweaking or tweaker behavior, or someone is tweaked, means they are really wound up or coming down from methamphetamine. Again, going back to nursing considerations, if you have this individual in the emergency room, they may come in seriously desperate, asking for help. But once they start to crash, you're going to see not only a behavior change with the tweaking behavior, which is alarming for people to see if they've never seen it, but then also the anger and violence comes as they want to get out of there to get what they need. So there's risk for harm to them. There's risk for harm to the caregivers. And really the only arsenal of medication that there is to treat this is the ones we are already aware of. Some places still use Haldol, other places frown upon that. Some still use Ativan, same thing. There's different schools for different places. But it isn't, there's nothing else in our arsenal to help treat methamphetamine dependence or withdrawal. So the tweaking behavior is an identifiable behavior. And I'm going to, coming up on, oh no, it's in the other slides. I'm hoping we can, I can get them to you fairly soon, but there's before and after photographs of someone who has been using methamphetamine for a period of time. And I think there's the one that's on here, which you'll see, which is pretty startling, is a woman who, it was only a year from the time she started that you see the after picture, and it's really hard to look at. So Donna, if you go to the next slide. So signs and symptoms of methamphetamine use disorder. Obviously, I'm not going to read them all to you. What I tried to do is break things up into sort of physiological signs, things that are more psych-related or mental health related. And as I tried to break some of the stuff into spiritual kind of, I realized that a lot of the psych and the spiritual go side by side. You know what I mean? The profound guilt that somebody has for the destruction they've caused, not only in their own life, but in the lives of the people they care about. So those sort of things that are also psych-related also fit into the spiritual category. But if you look at the physical, the dizziness, the facial tics, the headaches, as I was putting all this onto the slide, I thought to myself, this does not look like a good time to me. And I'm not laughing at anybody's situation, but I know that from when a chemical gets a hold, and that's all you can think about is getting the next dose, or the next fix, you don't stop to think of these effects. But in their entirety, what this really shows is that every system of the body is impacted. And when you meet individuals sort of at the end of their road, you hope that they're going to hopefully get treatment with some success, is that you can see that every area of their body has been impacted. We're a very, I would say we're a very visual society. How we look is important to us. And when you see the profound changes, it's amazing that anybody would continue. When Donna shows that definition of addiction as being illogical, compulsive drug use, it is illogical to be feeling all this and think you're going to go do more. But that is the power of addiction, as we know. So then the psych, there's the anxiety, the depression, and how do you sort all that out when what you're adding to the soup, for lack of a better term, is a drug that is so powerfully going to shift how you feel. So we're talking about large swings in moods, substantial swings in depression or almost manic highs. Along with that, of course, goes risk-taking behavior. So on one of the slides coming up, I think I have down there to think about risk for what. There's a lot of things you can fill in what this population is at risk for. If you go to the next slide, Donna. Okay, so here's the photographs I was about to tell you about. So here on the left is an example of the physiological impact on dental hygiene from chronic meth use. So this is the term they use for this is called meth mouth, and it's very you see it commonly in this population, and it's always the same. It's like wear and tear on not only the gum line, but the actual dentin and structure itself. But you can also see how the teeth have I don't know if this person had misaligned teeth to begin with, but a lot of the reason folks end up with teeth that are all in different directions is from grinding the teeth. So methamphetamine, a methamphetamine high, the majority of people, one of the signs you'll see is they're grinding their teeth all the time. This is the result of that. This very disturbing and sad photograph on the right breaks my heart to see that. This is 1 year of meth use for this woman. She went, I've never met her, but she went from looking the way she does here in the before to this in a year. And that is just so profound. It's hard to imagine. Donna, if you go to the next one. So symptoms of withdrawal. And withdrawal is a rapid process. So just like any other drug, and what I've tried to do is sort of put this in between as we went along, we know that people build a tolerance to benzos and opiates and alcohol and any other chemical of craving. So methamphetamine is no different. Someone can start off low, and over time they build a tolerance. So therefore they're smoking more, or they graduate from smoking to injecting. And once they sort of make that switch to injecting, the slide downhill is much more rapid. If you can imagine that someone is taking a handful amount of methamphetamine, and the reason I'm pointing this out specifically is if you are a nurse and you are trained to give a proper dose, right? 0.5 mLs, it's going to be 0.5 mLs. What you'll see with folks who are using crystal meth, if they decide they're going to bump it or they're going to point, they'll just grab a pinchful. They have no idea how much that is, really. And what is used typically is an insulin syringe. And someone will say, I do a 1. And what they mean by that is crush up the methamphetamine, pack it into the insulin syringe, and have it filled to the, I believe it's 0.1 on an insulin syringe. So that's what they mean when they say they want a 1 or 1.5. Now, I knew somebody several years ago who every time he pointed, at least 4 times a day, he was doing 7s. So that is a massive amount of methamphetamine going into a vein, into your bloodstream, directly into the central nervous system and into the heart. The physiological response you'll see that individual have first, once the drug hits the system, is deep, hard, profound coughing. It literally takes the breath away because the high rush is so hot, so rapid that literally you'll see the person try to catch their breath and cough and have a vasovagal response possibly. So once a tolerance builds and somebody gets to that point, the half-life becomes shorter and shorter. So if you smoked in the past, I don't know, smoked for an hour with friends or acquaintances, and you didn't for 4 or 5 hours, that is going to change as time goes on. And once you start pointing, people will point multiple times a day. The longer somebody uses and the larger the volume, the worse the withdrawal symptoms are. The only treatment, as mentioned, I'm trying to look at the time because I haven't looked, is supportive. So if a person goes to a rehab, they're going to get the same withdrawal type meds that someone might get for opiate withdrawal. Obviously, the medication-assisted treatment meds are not targeted for methamphetamine, but they can at least get some anxiolytics and hopefully something to help them sleep. But the worst part, I've been told by people in treatment, is what they call the crash. So if you can imagine the body physiologically being charged up on massive amounts of stimulants to the point that people can be up 3, 4, 5 days in a row. People will tell you that they've not slept in 5 days, 6 days. I was on one cruise a number of years ago where someone on board jumped overboard on day 5. And it was reported that he had not slept in a week. And that was from his methamphetamine use. So those high quantities, long periods of time, you can imagine that the withdrawal symptoms are more profound. And with the crash, basically, we're talking about people sleeping 15 hours, 16 hours, 20 hours, having to wake them up to drink fluid and take nutrition. Because the body basically, after all of that running, and the physiological ions burning constantly, their body just finally literally crashes. That's why they call it the crash. The muscle spasms, fevers, sweats, all of the withdrawal symptoms. Donna, if you could go to the next slide. So I can't even believe I'm here already, but, and this isn't even, I don't think, very much information, but so if you, basically I'm trying to wrap up some conclusion here that amphetamine, including methamphetamine, is another use disorder or addiction problem that is pretty serious, obviously, and is all over society. And it's not going to go away anytime soon. It also is brain-based, just like all of the other substance use disorders. It is the same reward pathway. Individuals who use methamphetamine feel rewarded by that drug, just the way somebody might feel rewarded by chocolate or sexual impulse. Understanding one's own risk factors is important, but when you also consider the risk factors involved with injecting a drug like methamphetamine with all the chemicals, as well as the risk-taking behavior that goes along with it, a lot of that amped up energy also increases an individual's sexual drive. So we're seeing people with massive amounts of STDs coming into clinics, and there are those who, of course, are going to trading money for drugs, and just as we see with other chemicals. So individuals being treated for amphetamine, including meth, are at extreme risk for injury and self-harm, especially in the crash phase. And currently, there's no options available, as I already mentioned, for medication-assisted treatment. So just the standard that's already out there. As I already mentioned, the success rate is pretty low. And those who have gone into treatment, who, again, a pretty high recidivism rate, one of the most difficult things for those folks is to find someone. Unlike AA and NA, you can walk into an AA meeting and find, 15, 20 people with 10, 15 years of sobriety, right? You go to a CMA meeting, Crystal Meth Anonymous meeting, and you might meet somebody with 3 months. 3 months of recovery, not using meth is considered like, that person's like a rock star. So, and if someone is going to give up their methamphetamine habit, this also means they need to give up their entire social circle, more than likely, because that is the group that they are hanging with. That is what they see as their support system. But who is going to stay stopped if you're still with your support system? So it's a real challenge for someone to stay stopped. Donna, would you go one more? I'm trying to remember. So also, I really, coming back to the nursing issues, really think about the risk factors, and there are just so many between the malnutrition and the STD risks or STI risks and risk for assault, and that was kind of the message I wanted to bring more towards discussion. But at this point, I'm not sure how much time we have left. If there's anything I can answer for anybody, I don't know if this is helpful as a foundation for folks who have not seen or heard much about this yet. I certainly have a wealth of more information if anybody wants it. And I left my email address here, so if anybody would like more information or to ask any questions, feel free to drop me an email. I'd be happy to answer it.
Adam, thank you very much. That was
Sure.
excellent. If you have questions, please post them in the chat room. We'll stay on for a few minutes to answer the questions. I think that was excellent. And the pictures you had, especially of that one woman, was so graphic and so
Oh my
telling.
God.
Yeah,
She breaks my
unbelievable.
heart.
Yeah. Yeah. So let's see what's in the chat here. So far, 2 great comments, very helpful presentation, wonderful presentation. Again, if you do have any questions, I'll be monitoring this. Post them in the chat room. And while I'm waiting for you to do that, Don't forget to tell everyone about the American Society of Addictions Nursing. Tell your colleagues to join. It's very reasonable to join. And if some of you in the audience have not joined, you really should consider joining. We will be doing this webinar series, and then the plan is to do a monthly webinar each month throughout the year for education purposes. Just check the chat room. Interesting. Increasing syphilis frequency in the Northwest. And thank you for the helpful information. And what I was going to say was, you know, a few years back, and I'm on the East Coast in New Jersey, obviously, but we didn't see a lot of methamphetamine use, but now we are seeing more and more and more all the time.
It's true. And I think the online way now of, people call it socialization. I call it desocialization. With the online way of meeting folks, there's lots of chatter on the sites about this code language. You know, somebody will say, I'm going dancing tonight. Tina and I are going dancing. Tina is a code word for crystal meth. If somebody says, I'm going out with Tina tonight, that means I'm going out and I have crystal meth. Somebody may also say, oh, well, has anybody heard from Gina? I haven't seen Gina in a while. Gina is a code name for they're looking for GHB. So you can go onto these sites and see this language going back, and it looks like they're having a conversation about meeting up with somebody else, right? It is the plan for the gathering and who has what. And it's really an interesting thing to watch when you learn about it and you actually go and check it out. And it's just become a big part of the fabric of pockets of, I don't want to label people, but I call it like individual sub pockets of communities, you know, where people hang together and they sort of have their own code language. But the combination of stuff is really scary.
Donna had raised a question. Do you see rhabdo with meth?
Oh, absolutely, yes. So one of the things that happens for a lot of folks with methamphetamine addiction is, I hate saying it because I have chronic dry mouth from my other meds, but I have chronic dry mouth. Chronically dry. Most of that is because their physiological energy is burning so much all the time that they use up, you know, a lot of their internal fluid sources. But people who are partying, they call it, forget to hydrate. So often what brings folks in is profound dehydration. And then, of course, with that, if you're not hydrating and you're not urinating, you have death of renal cells, and then you end up in rhabdomyolysis. And it is seen quite a bit. Also, there's a higher and higher incidence of folks getting cardiomyopathy from long-term effects of tachycardia, making the heart boggy, as well as valvular need for valve replacement due to injection site infections that seed the valves of the heart. So those are pretty big price tags, you know what I mean, that go along with that.
We do have some more questions too.
Okay.
What are some problems you've seen with prescribed stimulants?
So my big worry about prescribed, I mean, obviously there's a percentage of people out there that use stimulants the proper way. In 1985, I had meningitis. I had a very bad bout of meningitis, and post-meningitis, I was put on dexedrine for a year because one of the effects of the meningitis after recovery from it was I had a difficult time with concentration and memory. We all go to a drawer every now and then and go, why did I come to this drawer? You know, we all do that, right? Every now and then. I was doing that like 5 times an hour. Dexedrine, really, once I started taking it, focused my concentration, really relieved those symptoms. In a year, I was able to step off. It was not a problem. There are those who are now getting Adderall and Ritalin and those meds for a diagnosis of hypertension or, not hypertension, hyperactivity disorder. And they're selling them or trading them on the street for meth. And there are those who prefer to crush the Adderall and snort the Adderall. So any of those things can be interchanged. So my question always is, of the percentage of people who are getting prescription stimulants, what percentage of them are using them as prescribed? I think that would be an interesting study to look at. And I think there'd be those who are pretty surprised about how many are not using them the way they were intended to be used, either trading them for something else or using them in a different way. But we have no numbers because, again, most people are not going to admit that.
Right, right. The next one was the development of a care path includes fast track to psychiatry for off-label use medications to treat presenting signs and symptoms. Have you heard of contingency management?
Have I heard of them for methamphetamine? Is that basically what the question was asking? I've not
Right.
heard a lot of that for methamphetamine. What I was involved at Mass General when they were developing their addiction, their rapid response addiction consult team throughout the hospital. And one of the things that really worried me about some of I applauded the attempt to put some of these protocols together, but we're also talking about a population that it's really hard for those folks to stick to any routine of anything because their life is not routine. You know what I mean? So it's very, very hard to treat that way. But I think methamphetamine is so complicated because no one can say, well, I'm doing a gram a month or I'm doing an 8-ball a week. And these are volumes that it's sold in because there's no assurance that these values are accurate. So in order to create a way to treat somebody, you would sort of need some standard of measurement about how much have they been using in what period of time. Even that alone is hard to ascertain. So creating those kinds of protocols is really difficult to do. I would love to see it happen. I'd love to see someone have the option to be able to go somewhere and say, I'm trying to stop this. I can't stop the craving. And be able to be prescribed something like Suboxone to help them with that craving. That isn't here yet, as far as I know, for methamphetamine.
Okay, and then there's two other questions. One is relapse very frequent, right? Treat the depression, etc.
Right. So the relapse rate, there is no known exact measurement. I can tell you that the last 5 people I know that went to treatment for methamphetamine, well, one, unfortunately, 3 months ago, hung himself unsuccessfully, unfortunately. But the other 4 came out of treatment and were using within a week. So the recidivism rate is very rapid. And then I think, what was the other part of the question there, Al?
And then treating the depression, etc.
Right, treating the depression. So what's hard about that is most psychiatrists, when you try and talk about depression, you're talking about the symptoms of depression, right? Whether it be sleep disturbance or hopelessness. Well, if you're somebody who is meth dependent, all of those things are so off kilter that is it depression or is it a crash from a large amount of use? Is the person feeling depressed because they have quote unquote failed again at another attempt at recovery? Or is it that they feel so profoundly depressed because they're in withdrawal? Because remember when I said I tried to put some of the signs and symptoms into physiological, and some of them overlap so much that it's nearly impossible to tell what came first, the chicken or the egg. So I think the treatment regimen for folks with meth dependence is extremely challenging, which is probably why we don't have them. Trying to figure out how to treat it is the big question.
Yep. And then the last question is, what supportive medication works best with symptoms of meth withdrawal?
So what I'm going to say to that, I saw Bill there a minute ago. Bill, you're there, right? Bill Carrick, I think I saw you there a minute ago. This may sound a little controversial, but somebody told me about, they were trying to help a friend who was trying to stop his methamphetamine use. And the friend who was trying to stop his use kept saying, I really want to stop, but the craving gets so bad I can't stop. So sort of in the same vein of home detoxing, another person that is in recovery and knows him well stayed at his house for a month, had methamphetamine, and said to him, we are going to create a schedule where you are going to take a couple of hits from the pipe at 8 a.m., 12 noon, 4 o'clock, and whatever the other one was. Nothing in between. They started there. And then, to make a long story short, over the course of the month, made that less and spread out further so that when it was stopped again, it was a slower come down. It actually worked very well for him. So that's why that makes not a study, right? That's no study that I can say is a real study. But I guess my point is we know that even with opiate withdrawal, one of the things people go out and use again for is because they can't stand the withdrawal anymore. So because methamphetamine is such an illicit drug that it's not like I can say, oh, I'm coming to your house, I got a goodie bag, I'm going to stay for a month and withdraw you. But it does make sense that a taper might be the best way to go, as opposed to the sudden shock physiologically, mentally, physically, and spiritually for that body to come off that methamphetamine so hard. So I'm not suggesting it. I'm just saying I thought it was interesting that this person has maintained several months of clean time now. Oh, no, I hate that word, of sobriety time now, and has not used.
Yeah.
So that does say something for weaning down.
And then I think one other one just posted. Is fentanyl overdose frequent from lacing?
In
That's right.
methamphetamine, so methamphetamine is cut with a lot of things. Some dealers are cutting it with, baking soda, baking powder, whatever, just so they can stretch the dollar more. I've not heard of much, if any, fentanyl contamination, which I guess is a great thing because somebody's not going to die of that methamphetamine overdose as well. But I think it's a situation where fentanyl is harder to come by, and I think it's easier to mask meth with ingredients like that, the baking soda, baking powder, those things that you won't see as easy than it is some of the other things they're lacing with fentanyl. So I've not heard much fentanyl ending up in methamphetamine at this point.
All right. Well, thank you very much. We're about 8:05, so really appreciate you presenting tonight. It was an excellent presentation.
Thank you.
I think everyone learned a lot. I know I did.
Good.
So I want to thank you, and hopefully you'll present again for us.
Oh, I'd love to. Thank you so much. Thank you.
Yeah. And again, to everyone out there, if you're not a member of ASAM, we hope you join. And next week, I will actually be presenting, and it will be on holistic addiction treatment. So have a great week, everyone. We're going to end the webinar. Don't forget to do your survey to get your contact hours as well. Take care, everyone.
Thank you, everybody. Thanks.